Thank you for having me here. I'm really looking forward to the discussion that we go through. Wanted to start off just to orient you a little bit to our organization for those of you who aren't familiar with MemorialCare. We've got a complicated organizational chart here, but I wanted to start off just talking about our hospitals and what we call shared services, and to give you a map of where we're located. So this is southern Los Angeles County, down around Long Beach, down through San Clemente, through Orange County. And these are our 5 hospitals. Up at the top left is Long Beach Memorial. The purple circle with the dolphins is Miller Children's and Women's Hospital, the 10th largest independent pediatric hospital in the country. And then is Community Hospital of Long Beach. In the center is Orange Coast Memorial. And down in the bottom right is Saddleback down in Laguna Hills. In the center, the orange circle is shared services. This is where I work. We've centralized a lot of the administrative functions of the hospitals, things like legal and marketing and so forth there. So that's those 2 parts. I'm not going to talk about our health plan or the innovation fund tonight, but do need to talk about the medical foundation. You're all aware, I'm sure, that in the state of California there's a prohibition against hospitals directly employing physicians, but through a foundation you can have a professional services agreement with clinical organizations so that they will provide services directly to your organization, and then you can support them by providing infrastructure like buildings and staff and electronic records and so forth. Within our foundation, we have imaging centers, we have a medical group, an IPA known as Greater Newport Physicians, ambulatory surgery centers, as well as a joint venture with Fresenius to supply dialysis to our patients. So again, just to fill out the map, as it slowly expands, these are all of those things that I just mentioned, and you can see they span from southern LA County down through Orange County. So I want to start off talking about our medical group. Bristol Park was actually the name of the medical group back in 1961 when they were founded. They started their first professional capitation agreement, started taking risk back in 1979, and then signed their first full risk contract. I said about 1985, it was probably closer to 1989. And they became part of our foundation in 2011, celebrated their 50th anniversary, and then changed their name the following year to the MemorialCare Medical Group. Currently, they have 250 employed providers. You can see we've got 175 primary care physicians, as well as 40 specialists and 35 advanced health practitioners, nurse practitioners, and PAs. So our IPA division, Greater Newport Physicians, they started back in 1985 with risk contracts. And this is a group of independent practice physicians, primary care physicians. And so the only way for them to negotiate together was for them to take risk. And so for an IPA to be present, you have to have risk. So that's why they started off right at the beginning with that risk. They also started a medical services organization to help manage those practices. And they started taking full risk with Medicare Advantage in 1994, along with a hospital that's in Newport called Hoag Hospital. But in 2008, they separated their management services away from Hoag, changed the name to Nautilus, and then in 2012, joined the MemorialCare Medical Foundation and became part of our system. Currently, Greater Newport Physicians has 186 primary care physicians, and you can see the split between family physicians, internists, and pediatricians that are there. So this is a complicated slide I'm not going to go through, but this is from the health system, and this really represents the journey that the health system has taken over the last 20 years. You can see we started from 1996 at the top to current on this movement from volume to value. It has been a long road, and in the center of it is this 2011 start of the foundation, bringing in the medical group and the IPA, because the system recognized that if you're going to take care of the health of a population, it can't be hospital-focused. Hospitals are not going to do preventative care and manage chronic diseases. They're there for sick people. And so the focus really needed to be from our clinicians taking care of the population that was there. So in 2011, not only were they doing the foundation, but this application came out for the Pioneer ACO from CMS. This was CMS's first move into this area. And because the system had been going in that direction, they said, well, we've got to apply to this. And so they actually applied to be a Pioneer ACO. And were actually awarded to be one of the original 32 Pioneer ACOs. At the end of the year, you get your data. You can start sorting through it. And they started looking through the information on those patients and realized it was going to be a very long road to hoe to improve those, to improve the costs enough to make a dent, at the same time as integrating a medical group and an IPA into a hospital system. And they said, you know what, this is probably not the right time for us, and they actually declined right at the end of 2011, and so we're never listed as one of the originals. But that didn't stop them from that progress. So they integrated the medical group and the IPA into the system, started working together, and in 2014 put out a commercial ACO with Anthem. At the end of 2014, announced this collaborative arrangement, something called Vivity. I'm not sure if you're familiar with it, another very interesting discussion. But it's a collaboration between 7 large health systems in the Los Angeles and Orange County areas, along with Anthem. It is an HMO model, but there is full risk there. And then in 2015, another commercial ACO with Aetna. So we're moving right along. And then in March of 2015, this next generation ACO application thing came out into the system. We've been moving along this track. We were approved for Pioneer. This is an obvious thing. We're going to do this. So we submitted the application to become a next generation ACO. 1 month later, MACRA came out. And reading through it briefly initially, it looked like, well, physicians are going to have a choice. They can go into this APM thing, or they can go into MIPS. They get to pick. Well, we're going to be doing next gen, so pretty much most of our doctors will be in the APM. We really don't need to worry about this little law too much. This number here was actually what we were worried about. This is the number of attributed lives you need to have to qualify to be a next generation ACO. And so one of the confusing aspects of the application, and this may be difficult to read, is there were 2 lists that needed to be submitted. Participating providers, which is the top row, and preferred providers, which is the bottom row. And you can see the X's are pretty much there in the same place for all of them, except for those first 2 blocks, alignment and quality reporting. And we thought, well, quality reporting, we've got to report quality and be responsible for that anyway, so who cares about that? But alignment, that's the big concern. We need to make sure that we have enough patients, so we're going to put a lot of different doctors into this alignment category to make sure that we are going to hit our numbers. And then the proposed rule from MACRA came out, and suddenly we realized, you know what, actually participating means something completely different than what we thought it did, as does preferred. And so when we submitted our lists this past June for preferred and participating, we completely changed our approach to how we filled out those lists and who we selected to be put into those lists. So I'm out of time. I'm going to leave you hanging on that one. And I'm looking forward to your questions. Thank you.